Hello and welcome to our new topic. Ever wonder why we sometimes develop symptoms such as fever, body ache, and runny nose lasting a few days and then we get well on our own? This is usually caused by infectious agents. We are still confused to decide whether living or dead. That's right, they are viruses, causing a range of infections. While it's true that many viral infections are self-limiting and resolve without any sequelae, there are others which cause serious illnesses and lead to deadly diseases and epidemics. Only some of them can be treated with drugs. Those drugs are antivirals, and we would learn about them in this series of lectures. The learning objectives of this multi-part lecture are listed here. Please take a look. Viruses have some characteristics of living but not all. Hence, they are neither living nor dead. The only thing they always contain is nucleic acid. So they are packets of nucleic acids, either DNA or RNA, which replicate only after entering a host cell and utilizing its biologic machinery. Thus, viruses behave as obligate intracellular parasites. That means, to treat a viral disease, there are not many options available as targets. It also tells us why many antivirals would target the nucleic acids one way or the other. So, the principles of antiviral therapy include the following. Many viral illnesses do not require drug treatment because they are self-limiting. They depend on the metabolic machinery of their host, hence obligate intracellular pathogens. Difficulty in obtaining selective toxicity against viruses due to their such behavior. Many viruses adapt rapidly and show resistance against drugs and vaccines. Only the replicating viruses can be targeted. Many antiviral drugs are prodrugs primarily designed to be activated by viral-coded proteins or enzymes. Of course, a DNA or RNA would ultimately code for a protein. So, if you are able to stop the synthesis of viral protein or stop the assembly of protein at one stage or the other, yes, the viral replication and transmission can be stopped. So, the main target of antiviral therapy will be either to suppress viral replication or to stop transmission. Now, take a closer look at the 8 steps marked by hollow arrows shown here and the drugs targeting those steps. Try to figure out which could be a better way to classify these steps. This slide gives the Baltimore classification of viruses, with examples of human pathogens and important drugs against them. The colored circles with letters show a corresponding nucleotide to which that drug most closely resembles. The italicized drug names indicate that those drugs would be effective against another type of virus also. Let's start the first antiviral group. The drugs in boldface font are the main ones. Drugs for varicella zoster virus, VZV, and herpes simplex, HSV, infections include acyclovir, famciclovir, and penciclovir. These drugs are activated by phosphorylation, catalyzed by the virus-specific thymidine kinase in infected cells. The triphosphate derivatives are potent inhibitors of viral DNA polymerase, more selective to inhibition of viral DNA polymerase than of the host. Acyclovir, a guanosine derivative, must be activated by phosphorylation. The triphosphate form competitively binds and inhibits viral DNA polymerase, thus blocking DNA synthesis. Transcription is therefore inhibited. A drug of choice for parenteral treatment of herpes zoster, shingles, oral therapy for recurrent genital herpes, HSV-2, also indicated for HSV encephalitis and varicella zoster, chickenpox, generally well tolerated but occasionally can cause minor side effects. Trifluoridine, trifluorothymidine, is a fluorinated pyrimidine nucleoside that inhibits viral DNA synthesis in HSV-1, HSV-2, CMV, vaccinia, and some adenoviruses. It is phosphorylated intracellularly by host cell enzymes, and then competes with thymidine triphosphate for incorporation by the viral DNA polymerase. Incorporation of trifluridine triphosphate into both viral and host DNA prevents its systemic use. Application of a 1% solution is effective in treating keratoconjunctivitis and recurrent epithelial keratitis due to HSV1 or HSV2. Cutaneous application of trifluridine solution, alone or in combination with interferon alpha, has been used successfully in the treatment of acyclovir-resistant HSV infections. Valacyclovir is the L-valyl ester of acyclovir, hydrolyzed to acyclovir after oral administration via first-pass enzymatic hydrolysis in the liver and intestine, resulting in serum levels that are 3 to 5 times greater than those achieved with oral acyclovir. Among the frequent causes of blindness in the United States is herpes simplex keratitis. It is treated with trifluridine or acyclovir. Here we will talk about ganciclovir and foscarnet. These are also similar in mode of action, as we have discussed. Ganciclovir is a guanosine analog. It also requires triphosphorylation, just like acyclovir, and acts similarly. It can be given orally, intravenously, or locally. It can be given to treat CMV retinitis, or any infections caused by cytomegalovirus, whether it's retina, esophagitis, colitis, lungs. The most common adverse effect of intravenous ganciclovir treatment is myelosuppression, which although reversible may be dose-limiting. Other potential adverse effects are nausea, diarrhea, fever, rash, headache, insomnia, and peripheral neuropathy. Central nervous system toxicity, confusion, seizures, psychiatric disturbance, and hepatotoxicity have been rarely reported. Intravitreal ganciclovir has been associated with vitreous hemorrhage and retinal detachment. Foscarnet is an inorganic pyrophosphate analog, phosphanoformic acid, and does not depend on phosphorylation for activation and action. It inhibits nucleic acid polymerases as well as in HIV. It inhibits reverse transcriptase. Foscarnet blocks the pyrophosphate binding site of these enzymes and inhibits cleavage of pyrophosphate from deoxynucleotide triphosphates. The combination of ganciclovir and foscarnet is synergistic in vitro against CMV and has been shown to be superior to either agent alone in delaying progression of retinitis. However, toxicity is also increased when these agents are administered concurrently. Potential adverse effects of foscarnet include renal impairment and electrolyte imbalance. Saline preloading helps prevent nephrotoxicity, as does avoidance of concomitant administration of drugs with nephrotoxic potential. The genital ulcers may develop due to high levels of ionized drug in the urine. The M2 proton ion channel is a transmembrane protein in the influenza virus that forms a proton channel in the viral envelope. It functions to equilibrate pH by moving protons into the viral interior, a process crucial for viral replication and cell entry. They are active against influenza only. Rimantadine is 4 to 10 times more active than amantadine in vitro. The most common adverse effects are gastrointestinal, nausea, anorexia, and central nervous system, nervousness, difficulty in concentrating, insomnia, lightheadedness. More serious side effects, e.g., marked behavioral changes, delirium, hallucinations, agitation, and seizures, may be due to alteration of dopamine neurotransmission. The side effects are higher in amantadine than rimantadine, high plasma concentrations such as in renal insufficiency or advanced age, patients with seizure disorders, and may increase with concomitant use of antihistamines, anticholinergic drugs, hydrochlorothiazide, and trimethoprim sulfamethoxazole. Inhibition of neuraminidase, an enzyme produced by influenza A and B viruses. The enzyme neuraminidase cleaves sialic acid residues from cell surfaces, promoting the release of newly formed virus from the surface of infected cells. By blocking the enzyme, these drugs inhibit virus release from the infected cells. Early administration is crucial because replication of influenza virus peaks at 24 to 72 hours after the onset of illness. Initiation of a 5-day course of therapy within 48 hours after the onset of illness, 75 mg twice daily, modestly decreases the duration of symptoms, as well as duration of viral shedding and viral titer. Oseltamivir is oral, zanamivir is inhaled and peramivir is intravenous. All these drugs can cause neuropsychiatric symptoms and rash, although both are uncommon. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!